Hello. Thank you very much for inviting me to join this launch today. It's hugely important, and I'm really sorry not to be able to be there in person, but I got the opportunity to say a few words here. So I'm delighted with that, and I hope you're all having a fantastic day. My name is Fiona Gaughran. I am a Professor of Physical Health and Clinical Therapeutics in King's, and I'm the lead consultant in the National Psychosis Unit. And I'm here today to talk about obesity and its complications and causes as a comorbidity in people who have a primary diagnosis of psychotic illness. Obesity is a huge problem in people living with serious mental illnesses like schizophrenia and bipolar disorder. This is a review of the literature and meta-analysis done by Najma Siddiqui and her group looking at 120 studies over 40 plus countries, showing that about 26% of people with a serious mental illness are also living with obesity. And when you include overweight, that figure goes up to 60%. These rates are highest, the rates of obesity are highest in the North Africa and the Middle East. And overall, people living with a severe mental illness are 3 times more likely to be also living with obesity than are the general population. And this is particularly marked in women, who are about 44% more likely than their male counterparts to have obesity if they also have schizophrenia. So obesity is just one of many health risks affecting people living with severe mental illness. And this has been a topic of research and clinical interest for 10 to 20 years now, probably nearer 20. So we got together a group across the world and to try to create a sort of way forward, a blueprint as to how to protect physical health. And you know, it's you'll see on the slide here that on one side you have the sort of problems. Smoking is a huge risk, suboptimal prescribing, and not managing side effects, inadequate health promotion, and that fragmentation of services. And then the other side, the opportunities. What can we do about health policy? How can we go in early with evidence-based lifestyle programs? How can we make sure that our prescribing of psychiatric medication is really good, but also us prescribing of physical health medications and digital health, and where and how can we bridge that physical health, mental health gap? Because there are loads of system challenges, but the other thing that people talk about a little bit less is that if you have a mental illness that sort of waxes and wanes a bit, but when it's active, it's really can be quite all-consuming, and it's very difficult for you to manage your physical health at the same time as well. And if you're able to, and that's very difficult to, can be difficult. Sometimes people can have thought disorder. It's difficult to explain how you're feeling and what ails you to a clinician, and then it may be difficult to coordinate yourself to remember to take treatments, etc., because it can affect your concentration as well. So by the time people come into hospital, alongside the deterioration that they've usually experienced in their mental health, their physical health has also been compromised. And how do we make sure that the mental health acute admission for people with psychotic illnesses gives you space not just to think about your mental health needs, but also to make sure your physical health is as good as it possibly can be? So I'm going to give a couple of examples of that. One is to summarize Rebecca Martlin's PhD, which she's just finished. We're very aware of the high rates of sedentary behavior. So Rebecca was working with myself and Brendan Stubbs and Julia Onwumeri. And Brendan led on a review of the literature and indeed some data of our own, showing that rates of sedentary behavior are very high in people with serious mental illnesses, like about 9 hours a day when you're out of bed. And that's obviously not good for your health in the longer term. Rebecca reviewed the literature and found that high intensity interval training can improve not just physical health outcomes, but also mental health outcomes in people with mental illnesses. And she's published these reviews. There's also evidence that it can provide greater benefit to your cardiorespiratory system and your cardiometabolic fitness than moderate intensity exercise, and that evidence from the general population. So would it be useful for people experiencing an acute admission. Well, Rebecca went around and talked to patients and carers and staff, and there was a really positive attitude to get to see how people would feel about it. And people were very, very positive and felt it would help, and that, we haven't really got great systems to make sure that people exercise routinely all the time. So this would be, if this worked, it could be really useful. So she set up a feasibility and acceptability randomized control trial, which sadly had to stop after a few months because of COVID. But then we transferred that into a naturalistic study where we embedded the stationary bike and the HIIT exercise program in a couple of longer stay wards and rehabilitation wards and the National Psychosis Unit. And we looked at the outcomes, and overall, nearly 2/3 of the sessions in the randomized controlled trial were attended. And if people turned up to a session, they were over 70% of sessions were completed, which is comparable to other exercise programs. So people found it doable. There was a decent rise in heart rate noted, and mean satisfaction was about over 80%. So that was really positive. No adverse events noted. So we're hoping this will, this paper is being written up, but we're hoping that this will provide evidence to maybe improve the amount of exercise options on offer when people are admitted to hospital. The other area I'm going to give you talk a little bit about is about diabetes, and this is also a big problem in people living with severe mental illnesses. Jade Ashmont, she led on an analysis of data from primary care in East London, about 57,000 people, over 2,000 of whom had not just type 2 diabetes, but also had serious mental illnesses. And what we found was the groups that had both type 2 diabetes and an SMI were actually had slightly better glycemic management. The measure of the blood test HbA1c, which is your glycolated hemoglobin, showing that which shows your sort of glucose control over the previous 3 months, that was slightly better if you had both conditions rather than if you just had type 2 diabetes. But other inequalities came to light. In general, if you lived in an area of greater deprivation, that your HbA1c levels were higher, which is good, and also male gender was associated with higher HbA1c. People with type 2 diabetes plus an SMI were more likely to have an ethnic minority background, and they were more likely to live in more deprived areas. But they were also more likely to be excluded from the incentivized testing scheme, that pay for performance scheme. And we found that those people who were excluded from the scheme had poorer management of their blood sugars, poor glycemic management than those not excluded. And that was manifest with HbA1c levels that were substantially greater than in the group who were not excluded from that. So obviously there's a problem here. And Dipin Patel has been doing his MD research on seeing can we get prompts to help improve management of identifying dysglycemia in the first place and then managing it if it's there. So you can get electronic clinical decision support systems where you can set up the electronics to be able to put a prompt in the clinical notes so that so that you don't forget to provide good care, that to signpost you to good care, to whatever's necessary. And there's good evidence that in diabetes care, that actually electronic clinical decision support systems in the general population can be effective in the community. Now, there isn't that much evidence, and it hasn't been done in mental health settings, so it does need to be done in our settings here. So what we did was we sat down with Omar Mustafa, who is our diabetologist, and adapted a clinical algorithm, which was adopted and approved by the trust, and then adapted into electronic form into what's called CogStack. And CogStack allows us to search the notes in near real time and can allow for prompts to go within the notes to prompt good practice. So it links clinicians to guidance for management of higher HbA1c levels and how to prevent the development of diabetes, which can, of course, be associated with obesity. So at the moment, Dipin is just analysing the data from his feasibility and acceptability trial using an electronic clinical decision support systems to improve dysglycemia management on the wards. And And, one of the first challenges we meet is sometimes when people come in, they're not feeling well in themselves, and they may not want to have a blood test straight away. So how do we make sure that we remember to come back and talk to them about it again before they go home? So the system is set up to be able, if somebody comes in and the computer will wait and check, wait for a blood test to come in the first 3 days. If it hasn't come in the first three days, we'll prompt the blood test. And then when the blood test results comes, we'll link the clinician, send an alert linking the clinician to what is the advised practice for that particular blood test result. And it's really quite structured, so the content is easy enough. What we're really assessing here is how this lands in practice. So do people open the alerts? Do they act on the alerts? Do they find the alerts helpful? What do they think is useful? What do they think gets in the way of it? Are there any unintended consequences, etc.? So DIPN is analysing data from surveys and semi-structured interviews, and we're going to be looking to see, is this well received, and does it improve care? And we're hoping that if it does, then it will provide a basis for future work for a sort of wider program to be able to see, can this improve our health outcomes? So those are just a couple of examples of how we can take novel approaches to make sure that we're giving people the best possible care when they're admitted to hospital. There are lots of other examples, but I only had a few minutes here. So I wanted to thank all of you for listening, but also to thank our funders, to thank the researchers, our academic colleagues, our clinical colleagues, staff, and the patients who have been involved in these studies, and also the people with lived experience who helped us develop these studies. So thank you very much, and goodbye. And I wish I was there with you in person, but I look forward to see the work coming out from Crewe. Many thanks. Goodbye.